Welcome to this next panel. It's an exciting discussion. I have a particular interest. It's an area I cover. The more extended bios are online, but just briefly, Dr. Margie Balfour is a psychiatrist. She is Chief of Quality and Clinical Innovation at Connections Health Solutions, which specializes in mental and behavioral care. She's been noted for her work with crisis response centers in Tucson. Lieutenant Christopher Gulli is manager of the crisis intervention team at the Arapahoe County, Colorado Sheriff's Department. My understanding is that all of their officers, and that is a big department, are trained in CIT, and that is the exception rather than the rule for law enforcement agencies across the country. Ginger Lerner-Wren is a judge in Broward County, Florida. She pioneered the first mental health court in the country. She has presented and written about it extensively and presented around the world on this. She is a regular at CMCJ. Hey, Ginger, it's good to see you.
Wonderful to be here, Katti.
Okay. And Christopher, please pronounce your last name for me. Slobogin. He is the Milton Underwood Professor of Law at Vanderbilt University. He teaches as an affiliate professor of psychiatry at the medical school, and he is a co-author of the leading case book and the leading treatise on mental health law. We are simply going in alphabetical order. Dr. Balfour, we'll go with you first. Thank you.
Well, thanks for having me. And just, I don't know exactly sure how you want us to kick off. Just talk about what we do and
talk about what you do.
Okay.
It's intersection in this sphere.
Okay.
And for all of the speakers, we're looking specifically for things that will drive the news narrative, story ideas for the journalists, solutions-oriented stories if you have them, and areas where there are deep troubles and just places that we need to borrow. Okay.
Gotcha. Yeah. So I so like I said, I'm a psychiatrist and I work in crisis services. And so I kind of live in the part of the system that is trying to prevent people from being arrested or having contact with police in the first place. So there's a lot of convergence now and interest in this area because of, all the unrest over the summer. And there's a lot of momentum in trying to minimize the police needing to respond to all these mental health crises. And so in order to do that, you need a crisis system that can receive those people. So if your officers are CIT trained and they're being asked to de-escalate people and then divert them to treatment, their first question is always going to be divert to what? And oftentimes the path of least resistance is still jail, because if they go to the emergency room, they often have to wait for hours, with the patients, and they're busy. They got crimes to fight. Or, if they go to, there's various different places, they'll get turned away because people are too agitated or too violent or too psychotic. So our Arizona actually has a pretty robust crisis system, and our center is kind of at the center of the Tucson system. And we also have a urgent psychiatric center up in Phoenix, where it's designed to treat law enforcement as a customer, because if you have the people that we want to keep out of jail, then we need to be able to service your needs. So our centers take law enforcement drop-offs. We never turn anyone away. And what officers want, they want to get in and out as quick as possible. So we 10 minutes or less, get them out, never turn them away, have all their, their little separate entrance where they can get everything they need done without having to walk around the facility and have people hassle them about taking their guns off, because that's the other thing law enforcement wants, is not to be bothered about taking their guns off. And then we receive these folks, and then we work on resolving their crisis. And so these are people who would have or could have in other jurisdictions been picked up for what they call nuisance crimes, like vagrancy or drinking in public or whatever, just to get them off the street. But instead, they can come to our center. They get seen by psychiatrists, social workers, peer supports, and then we're able to resolve their crisis most of the time after an overnight stay, and then get them connected to where they need to be. I think, and we exist sort of in a larger system where even before that, upstream, we've got a crisis hotline where anyone can call the crisis hotline and speak to a mental health clinician. They resolve about 80% of those crises on the phone. If they can't, then they are able to, dispatch mobile crisis teams, where there's 16 mobile crisis teams in the Pima County, and they can respond, and there's no police involved whatsoever. It's financed via Medicaid, and they can do face-to-face, and they resolve about 70% of those crises in the field. And then they can always bring to our center, just like the police do. And when you align all that together, it really makes sense from both the clinical standpoint and also from a financial standpoint, because what I want as a clinician is my patients to be not in jail, not in the emergency room, or not locked up in the hospital if they don't need to be. And if you're paying for stuff, you want those things too, because that is, it's much less expensive to have people in the community versus you're locked up in all these facilities. So there's a lot of momentum now for crisis care because of several things. The 988 is coming, which is going to be the 3-digit number that will connect to a mental health crisis line, and states are figuring out how to implement that. It's supposed to be done by July next year. And then they're realizing, well, gee, if we have this number, it needs to connect to something. And so the American Rescue Act has funding in it for states to get a higher Medicaid match to start to do mobile teams. And then, hopefully there'll be some more funding. I think the SAMHSA, the federal block grants got increased as well. And SAMHSA is planning to do a crisis set aside so that they'll
break down for the criminal justice journalists what SAMHSA stands for. I happen to cover health. Most people don't.
Sorry, Substance Abuse and Mental Health Services Administration. So they're the part of HHS, Health and Human Services, that is focused solely on behavioral health, and they give a chunk of money to every state for mental health and substance use that then the state uses to fund care. And so they're going to, they got an increase in funding, and when they give their money to the states this next round, they're going to set aside part of it and say you need to use this to finance crisis. And just at every point along this crisis system, you want to have easy access to law enforcement. So out down here in Tucson, there's the crisis line staff co-locate with 911 so they can intercept some of those calls, and that never makes it down the police route. There's we have mobile teams, we have co-responder teams, and then our centers are designed to have easy access for law enforcement. Just as a kind of a final point is, people always ask, well, how do you pay for this stuff? And yeah, our crisis center, we have a beautiful crisis center. It was built via a county bond election, but our center in Phoenix is just, we lease it from a decommissioned hospital that we remodeled. I think the important thing is that the actual services that are provided, and I'm talking now about the crisis line and the mobile teams and our center, is primarily financed via Medicaid. You hear all this talk about, well, let's, take, shift money from municipal budgets, from police to mental health care. We don't, this is where I get on my soapbox and then I'll be done so other people can talk, but we don't talk about robbing municipal budgets for any other health emergency except that with a psychiatric diagnosis. And, it's healthcare. So all these services ought to be funded by the healthcare system, just like a heart attack or a stroke. All that. Arizona has this great crisis system that I just described. This is a story. If someone, sorry about my cat there. So if someone calls a crisis line, gets a crisis counselor on the phone, then a mobile team goes to their house and sees them, then they take them to my center where they see me, and we resolve their crisis. If that person has Blue Cross, at the end of the day, when they settle up about where that money comes from to fund all of that, it comes from the state line item budget or for indigent care for crisis services, because private insurance doesn't pay for any of this. And that's, I think, a parity issue, that, funds that are designed for indigent people are picking up crisis care for, how much does the CEO of Blue Cross make? So that's just some things to throw out there. And there is a report I'll put in the chat there's really no national standard for crisis services because it is primarily financed via Medicaid, and every state does its own thing. But now with all of this momentum, there's there's groups that have been working on national standards, and the National Council for Behavioral Health just put out a blueprint for communities that want to start to build crisis services, and that has measurable standards of progress. And I was part of the writing group, and so that just came out, and I will put that in the chat and then let other people talk.
Thank you. If I had been thinking, I might have had Lieutenant Gulli go first. I'm going to have him go second, and that's fine. Thank you, Dr. Balfour, and I'm going to stop with honorifics. Thank you, Marjorie, for setting the stage. Christopher, you're on. Thank you.
All right. Well, just to small correction, Katti.
It's not all your officers.
Huh?
It's not all your officers who are trained. I read that online. You should not always trust what you read online. Okay.
And I'll explain why. The last sheriff administration wanted everybody to get CIT officer trained. However, according to the Bureau of Justice, the United States District Attorney, and the organization CIT International, you shouldn't have all your officers trained. The Justice Department and the USDA said in their Cleveland consent decree when they took over the Cleveland Police Department not to have it, should be a volunteer basis. And the explanation is this: if you go to the emergency room with a heart issue, the doctors and the ER docs can stabilize you to wait for the heart surgeon to get there. The heart surgeon is the one you want doing that surgery. You don't want the ER docs doing a quadruple bypass. You want the heart surgeon to do that. That's the same philosophy with our officers. Is we're all mental health first aid trained. So we're all trained for mental health first aid. And I had to convince, after spending a lot of time with the CIT International folks and talking to them, because they're the ones that created the CIT programs and the whole idea about CIT back in the late 80s in Memphis, Tennessee, that it should be still a volunteer basis, but everybody should be mental health first aid certified. That way you can get there, you can triage the situation, you can calm the situation down, you can settle it, and then get a CIT officer. Or now we have actually co-responders with our agency. So we have co-responders who are social workers and mental health people who come out to calls that are substance abuse, that are housing issues or food issues or mental health issues, and they can come and get these services for our citizens. So that's the biggest thing, is that we're incorporating this mental health co-responder program along with our CIT co-responders. So we have now, I was an officer in Arizona, in Tempe, Arizona for 5 years. So I'm familiar with the Arizona system that they have, and they have a better system than Colorado does. And I've been up here for 16 years, and I will tell you that in 16 years, it hasn't improved very much up here in Colorado. But what we can do is we can take people with the co-responder to the hospital on a mental health hold, leave them at the hospital, leave them at the mental health facility, and have a co-responder do all the paperwork. So we're back in service really quick. So that is the goal now with our agency and with most agencies in the Denver metro area, is to get these co-responder programs up and running. And we have our co-responders go to calls that are nonviolent. Someone's just having a bad day, feeling suicidal, but they have no weapons, they haven't taken any drugs, or they're just feeling like they want to harm themselves. We have them go to those calls by themselves. But if there's a weapon or anything else involved, we get there, we make sure the scene is safe and stabilized, and make sure everybody's safe. And then our philosophy is we just kind of back off, and we're like wallpaper. We just stand and we blend in with the background and make sure nobody gets hurt, and make sure the co-respondent can do their job. And as long as they can do it safely, we just stand back and we don't say anything. So that's the biggest thing. I've been in charge of our CIT program for 5 to 7 years now, and it's a pretty successful program. We take people from all over the state, and they come into our agency. We do a 40-hour week-long class, And like the doctor was saying, we didn't get into this job, and I didn't get into this job 20 years ago to be a mental health clinician. I don't know how to. I didn't do enough school. I went to Arizona State, but I never took any mental health or psychology. I only took one psychology class. That doesn't qualify me to be a therapist. But now that we're starting this partnership with our co-responders, it's something that we really want to get into the community. And now the community is buying into it, and they request co-responders. So you always know when a program's successful when the officers are mad or asking for co-responders when they're not there, and when they're taking a day off or a vacation day or sick, and they say, where's the co-responder? If they're asking for them, they like the program. And same thing with the citizens. If the citizens are calling 911 asking for co-responders, then obviously they like the program a lot too.
Before we move to Judge Ginger, how many of your officers are CIT trained, and what does that training look like exactly?
The training is a 40-hour, like I said, the training is a 40-hour training. It's a lot of local psychologists and sociologists and doctors that come in and talk about conditions and talk about stuff that is that people are going to encounter on the streets, and we try to get that training done for people that are 3 or 4 years in to their career, so they can listen to a doctor talk about someone who's bipolar and schizophrenic, and then in their minds they can go, you know what? That's Joe Smith that lives in District 1. I've dealt with that guy before. Now I can put a name and a face with the condition. So to have that experience is pretty important. Our agency is about 700, about 400 sworn. I think we're close to 60% CIT certified. So there's a good chance that you're going to get either in the jail setting, or or on the street, you're going to get a CIT officer on scene. And we're happy with that 60%. And we're happy also with having mental health first aid as part of our annual training curriculum. That way officers can brush up on it. Because there's nothing worse, and I think we all know that, there's nothing worse than someone that's forced to do something that they don't want to do. They're not going to put in the same effort that someone that wants to do it. And we have a lot of officers and a lot of people from around the state that, like I said, contact me to attend our class. And every year we have 30 people in the class twice a year. So we get a lot of officers. And a big part of our training is scenario based. So we have an acting company that we contract through that come in, and the person acts like they're schizophrenic, or acts like they're hearing voices, or acts like they're bipolar or hypersexual or anything like that. And the students are graded on each and every scenario that they do. And it's not everybody passes and everybody's good and everybody goes and gets a certificate at the end. We've kicked out and we failed out a lot of officers, and at least out of a class of 30, we at least 1 or 2 a class are fell out, that they just don't get how to talk to people like a person. And that's the biggest thing we teach, is just talk to people like you would want to be talked to. Talk to people like you would want to be addressed. And that's the biggest part of our class.
Thank you so much, Chris. Ginger?
Yes, hi. First of all, what an honor to be here. And it's always so fabulous to be with Katti and all of you. Chris, I'm a huge fan of your scholarship, and it's a real pleasure to meet you. And Marjorie, congratulations on your honor. And Chris, that was wonderful. I think that first of all, to the audience, the first thing I really want to say to you is you just don't know how important journalism is in terms of mental health, in terms of really helping the public understand, all of the barriers surrounding mental health, what it's like for family members that have lost their children, their adult children in the juvenile justice or the criminal justice system rather, and oftentimes people with mental illnesses, we know, because of a significant shortfall in resources and highly fragmented systems of care, And then, of course, the really huge problem of the stigma and discrimination surrounding mental illness, that people end up becoming trapped in the criminal justice system or endlessly revolving through the revolving door of jails and prison. And so it's a real honor to speak to journalists, and anytime I do get the chance, I just can't tell you how important your work is, how significant it is to write and write in a balanced way with regards to mental illness. And as a matter of fact, just to give you a little bit of history and how I came to pioneer the mental health court in the United States, I have a little bit of an unusual professional background. I am not what you would call a traditional lawyer. I started out my career as a public guardian in the court system, and that is taking care of the health, welfare, safety of adults who have been deemed to be incapacitated by whatever reason, disability or accident or something, or advanced age, by the probate court. So I began when I was in my early 30s in that career, and I was really, really aching to find a place in the law where I could do humanistic work, where I can do civil rights work and advocacy. And that program really gave me a great education. And while I was in that position as public guardian for the 17th Judicial Circuit, and by the way, I apologize, I'm a county court judge, a criminal court judge in Broward County, Florida. Many of you may know where that is. I'm sitting not in my courtroom, but in Fort Lauderdale, using my picture of my courtroom remotely. And I have been now on the bench for almost 25 years. When I started as public guardian, I was then asked to oversee, on behalf of the plaintiffs, working for, and I'm sure you probably all know what I'm talking about when I talk about Florida's protection and advocacy system. And in Florida, that state system that is federally certified, federally funded, is responsible for investigating abuse and neglect of persons with mental illness, of children with mental illness, of individuals with all kinds of related disabilities. And it's a pretty broad statute. It has a lot of teeth in it. And I was a PAMI lawyer, and I was asked to oversee a federal class action at the state psychiatric institution that was located in Broward County, but it actually served the bottom half of the state of Florida. It was during a time in the mid 1990s when the hospital itself, was a pretty inhumane place, which is why there was a federal class action. And this particular settlement agreement had been reached. And I was hired from the public guardian's office to serve as a plaintiff's monitor. And usually, if you cover federal class actions, most monitors are court monitors. They report their objective, they report to the court. This was a very unusual federal class action by the name of Sanborn versus Childs. And Lawton Childs was the governor at the time that I was involved in that lawsuit as a plaintiff's monitor. And I represented on the ground every day all of the patients that lived in the hospital, that were essentially living in the hospital, patients at the hospital. They were the class, they were my clients. My job was really pretty complex job, but largely to oversee the the discharge planning and the quality or lack of quality of discharge planning of our class members. And then I would follow them into the community and I would report back to General Counsel, and that was Southern Legal Counsel in Florida. And the idea was to drive, I know it sounds complicated, but bear with me, I promise I will connect the dots for you. My job was really to help lead the capacity of building of systems of care in the state of Florida that covered these catchment areas, essentially the bottom half of the state. And I served in that position for about a year and a half, and plaintiff and monitors do have a shelf life. And I was trained for that role by some of the nation's most leading experts in all disciplines of mental health, mental illness, systems of care, psychiatric rehabilitation from a person-centered approach, mental health consumer rights. So here I am getting trained, training lawyers and law students would never get in law school. And so I left that position. I ran for elected office in 1995 with all of these skill sets. And sure enough, I ran for office with these really fabulous iced, spiced, individually wrapped gingerbread cookies. And I was elected without opposition. I give it to the cookies. And when I came to Broward County's judicial system at the time, we were experiencing a tremendous amount of problems in our jail system. It was overcrowded. There was an overrepresentation of persons arrested with mental illness. There was a number of suicides in our jail, and a very high profile case of a young man by the name of Lerner-Wren. And that is an hour in itself to talk about the case of Lerner-Wren. And Katti, excuse me, did mention my book, A Court of Refuge, Stories from the Bench of America's First Mental Health Court. It is dedicated to Lerner-Wren, who PBS and Frontline called the unlikely savior of a new system of justice. And when I came to the bench, there had already been a grand jury investigation of Broward County's mental health system. Just in case you don't know, Florida, first of all, is the third largest state in the United States. Broward County has essentially, I think, 2 million people. Florida has no Medicaid expansion. Only 13 states in the US have no Medicaid expansion. And Florida was essentially at the bottom of the funding rung of the ladder for persons with mental illness. I think we were getting essentially at the time less than $40 per capita. And so what the grand jury found in 1994 was essentially that nobody was getting care for anything, and essentially there was no one in charge, no leadership in our county-wide system. And the grand jury report spurred a task force, a high-level, high-powered, interdisciplinary task force where, and this is important, for the very first time, a mental health system that was highly siloed from substance use, behavioral health, human services, and every other system of care came together, and they met, and they were seeking solutions on what to do in our criminal justice system. How could we streamline the processing? Judges weren't trained in mental illness. They would see people in court who were arrested, who may have been psychotic, very unwell. Judges would hold them in contempt. They thought they were, misbehaving, acting out on purpose. They really did not know what they were witnessing. And sure enough, finally, after 2 years of meeting this task force, I wasn't on the task force. That's when I was running in really almost a Hail Mary, type of moment. The chair of the task force asked our chief public defender, what is it that you think we ought to do? What do we need to do? Everybody was getting extremely fatigued. There was no will for CIT. And the public defender at the time, who just retired by the name of Howard Finkelstein, said, I want my own specialized court. I don't know that he knew exactly what that would look like, but we did have a drug court in Miami-Dade that had been established through the leadership of then State Attorney Janet Reno, who was now the Attorney General when I came to the bench. And, we didn't have any money. We had no funding. We had no grants, but what they did have essentially was a rookie judge, because I never even did a criminal case. I was a disability rights lawyer. And, but what we did have, and this is another big takeaway for our journalists, is never underestimate the power of a small group of people, as Margaret Mead said, to come together and lead change. And that is exactly what we did have. We had a courageous community, NAMI members, a few judges, and community stakeholders across these systems who had come together, and they just didn't want to be part of this conveyor belt of having people arrested with mental illness going into the jail system. I was trained in discharge planning in my role under the class action that I had been working with. So to our journalists, when you think of discharge planning from a hospital, it's really essentially the same as diversion out of a jail system. So you have discharge planning, you have the concept of diversion, you have the concept of reentry. And if you look across a sequential intercept map, which I bet you covered in your reentry program, you kind of see, where all these intercepts take place. I am essentially in the mental health court a post-booking diversionary strategy. Lieutenant Christopher and Dr. Margie, they are both community and pre-booking strategies, correct? I am post-booking. And that means that we are looking to intercept people as quickly as we can upon their arrest. We created an open referral system. My job, I have no authority, for example, to commit anyone. I have no authority to order people involuntarily civilly committed if they are acutely ill. And we know, Dr. Balfour, when there is crisis, how many individuals are acutely ill. But what I did do is I developed a court order, basically ordering our sheriff's office to transport Jane Smith out of the jail to the nearest receiving facility or psychiatric unit for an independent evaluation and screening to see if they need hospitalization. That's really in a triage. Those are the people that we were looking for first, those of the sickest of the sick. And then, of course, if people had homes to go to, et cetera, that's fine. We hired, actually, we got a volunteer as a clinician. I decided that everything needs to be out in the open. Everything, the pain, the frustration, the angst, just the joy of people getting the help that they need. But we really wanted everything out in the open. I think that when our court started, believe it or not, in June of 1997, we're going on 25 years in June. We didn't know, but I really think that as soon as the first AP, this is how important journalism is. as soon as the first news story broke about Broward's new mental health court and what it was intended to do, and we do consider ourselves a human rights strategy because we do consider the criminalization of people with mental illness a human rights violation, that, you know, flocks of delegations and people from all over the country came to see what we were doing and how we were doing it. Jump ahead now on coming to our 25th year. We've diverted, and this is a part-time court. I have a regular traditional division as well. We've diverted over 23,000 people. Yes.
Wonderful. Thank you.
You're welcome.
Chris, because we want to save time. I know there are a ton of questions. Chris, if you would jump in, and I hope your presentation somehow parses what's happened as a result of CIT and mental health courts. I hope.
Well, I guess usually I am last on the panel because of my last name, and this time I think it's good that it worked out this way, because actually what I'm going to talk about comes in after what we've just heard about. I was going to do a PowerPoint, but I think that's probably going to take too long. So I'll just make a couple.
But if you email it to us, then we can.
Yeah,
share.
I'll email it to you. So one thing I think is important to get straight, just to set the context, is that according to a number of different surveys, at least 50% of the people in prison and jail have some kind of mental disability, and serious mental disability, probably at least 10% of males and 30% of females. So we're talking about a huge part of the population that's incarcerated, and that's compared to, for instance, about 4% of the general population. So what happens to them? Well, hopefully they're diverted out of the system in the ways we've just heard described by Dr. Balfour, Officer Gulli, and Judge Lerner-Wren. If they either have a less serious crime or they're considered low risk, they should be diverted out, but that's not always what happens. And a lot of them are, of course, subjected to prosecution. Every year there's about 15,000 to 20,000 people who are subjected to prosecution despite the fact they have serious mental illness. And the issue that comes up in that context is whether they're competent to stand trial. The Supreme Court of the United States has held that a person cannot be tried unless they are competent to stand trial. And as many of you know, the test that was described in Dusky versus United States is whether the person can understand the proceedings and communicate with counsel. And I just want to talk about three issues that journalists should be aware of in connection with the competency issue. The first one is what could be called the revolving door problem. The person found incompetent gets sent to a mental hospital, is restored usually on medication, they're sent back to jail to be tried, and they decompensate in the jail. That's a horrible, horrible thing to have happen. Every time a person decompensates, it harms them psychologically and in other ways. Ideally, that would not happen, but it happens all the time. Judge Lerner-Wren, I'm sure, knows about this case, the case of Bobby McGee, who went back and forth between the hospital and jail 6 times, decompensating every single time, cost the state of Florida $1.3 million by the time he finally got to trial. Totally idiotic situation, but it's what happens because jail staff either don't feel qualified to treat these people once they get sent back to the community, or they're worried about getting sued because they didn't do the treatment correctly, or they are not sure about their legal liability. There are various legal ways of taking care of this situation. One is the hospital can do a very good job providing a treatment plan for the jail staff. Jail staff can have the right people on board, like people like Dr. Balfour. They're on the jail staff. They can provide the treatment, but a lot of jails don't have the requisite staff. There's also the possibility of telemedicine. That is, treat the person in the hospital, make sure they're restored to competency, keep them in the hospital until the trial date is definitely set. So that's issue number one. Issue number two, some people cannot be restored to competency through medication. It's just not possible. So the Supreme Court has held, but you can't keep that person forever. In the case it held that it came down with that decision, Jackson versus Indiana, the person was a deaf mute who had stolen a total of $9. An attorney found him in the back rooms of a hospital 3 years later. He'd been found incompetent and sent to a hospital. Was not restorable. You could not restore him. Either his mental illness was not treated, or because of his other problems, he was not competent to stand trial. The Supreme Court said you have to restore these people, or civilly commit them, or release them. So what has been the state response? Well, actually, Arizona's response has been pretty good. Arizona said if a person cannot be restored within 20 months, have to civilly commit them or release them. That's unusual. In the state of Florida, where the judge is from, you can keep a person for up to 5 years. And even at that point, you can dismiss the charges with prejudice, meaning you can restore the charges if the prosecutor wants to. In Texas, you can keep them for as long as the length of the maximum sentence that would have been imposed had the person been convicted. All that, to me, my personal opinion, is unconstitutional. In your state, you need to find out what's going on with these folks. This is issue number 2. There are class action suits now being brought on behalf of people who've been in the hospital for years after being found incompetent. They shouldn't be there. It's unconstitutional. Issue number 3, very briefly, as I've mentioned a couple of times now, the way you restore people to competence, usually if they're mentally ill, is through medication. Well, medication has very serious side effects. And so one issue that's been litigated is when it's permissible to force medication on people. And the Supreme Court has come down with a couple of decisions in this regard. Those of you in Arizona know the Jared Lerner-Wren case. He's the person who killed a federal judge and badly harmed Representative Gifford. He was found incompetent to stand trial, sent to the federal facility, and wasn't treated for months upon months. Why not? Well, I'm not going to go into in detail unless you want me to, but essentially his defense attorneys, and I think they were acting the way they thought was appropriate, said, well, he's refusing medication, and so he shouldn't be forced to take medication. On the other hand, his psychological condition was horrible. And the Supreme Court has made it clear that if the state has a compelling interest in medicating someone, they can forcibly medicate that person. What would be a compelling interest? A serious crime. Well, the Jared Lerner-Wren case obviously involved a serious crime. He killed a federal judge, among other, at least allegedly killed a federal judge, among other things. Secondly, if the person is dangerous to self or others, Jared Lerner-Wren was definitely dangerous to self. Or, and this is the big exception, if the person is incompetent to make treatment decisions. If a person's incompetent to stand trial, they're probably incompetent to make treatment decisions. So I've gone through that all very quickly, but I know we're running short of time, so I'll stop there.
Thank you. We have some questions that have already popped up, but if I could start with the first couple of questions. What data is there on the severity of mental illness of people who are justice involved? I mean, who is severely mentally ill, schizophrenia, bipolar, the things that may be a little more complicated, and who's on the other end of the spectrum? Is there data on that?
You know, I think that there is data on that. I apologize, I didn't bring that data with me. Obviously, I think that individuals with thought disorders, are more prevalent in the criminal justice system. And then, of course, you have individuals with all kinds of co-occurring disorders. And that is a very significant prevalence. That is, when I say that, I'm really talking about individuals with substance use disorders, as well as some kind of mental illness or neurocognitive disorders. And we also know that a vast majority of individuals in prisons and in jail have suffered significant incidents of trauma and victimization. So that, across the board, it's pretty rare that you get individuals like with one diagnosis or another. And I think Crystal, and Dr. Balfour, oftentimes individuals will have a number of varying diagnoses depending upon who they see and what's happening. But clearly, I think individuals with schizophrenia, are very prevalent and probably the most significantly at risk in the justice system.
So if I can reframe the question a bit. So if diversion courts and CIT and all of this is designed to keep people out of prisons and jails, how many people can be kept out reasonably? I mean, how do you change this universe? How do you make it smaller? How possible is it?
I think that's really the big issue, isn't it? And I think that it's pretty evident. I mean, you will never hear me, and I do a lot of public speaking. I don't hail mental health courts, nor do I hail CIT as innovations that are an answer. These are strategies. What we do need is we really need fully resourced, well-financed, evidence-based, research-driven, welcoming, vibrant, front-end systems of healthcare, mental health care, behavioral health care. So we don't necessarily have to have these crisis systems. They're really not necessary. It's just that these shortfalls in mental health spending are historically just really devastating. And it goes back, of course, for centuries.
Margie, would you weigh in, please?
Yeah, I think a lot of it, I agree with what a lot of what you're saying. It starts with never having these folks in the justice system in the first place. Like if I call 911 because I'm having chest pain, I get an ambulance. But if I call 911 because I'm suicidal, I get the police. And so from there is where it starts. We talk about like how many. So at our Tucson facility where I'm at, we get about 500. We're a county of 1,000 or of about 1 million, and we get 500 law enforcement drops every month. And pretty much any one of those could have been picked up and to get them off the street, even like a well-meaning officer going, well, gee, you need to at least get you some help in jail, which is completely backwards, but it's, kind of where a lot of places are. Many of those could have been picked up on some kind of, vagrancy, trespassing, that kind of stuff. The officers here have the discretion to not arrest people. They have their criteria. I believe it's around like, if there's a crime with the victim, like it's domestic violence or something, they have to take them to jail. But aside from that, they have pretty broad leeway, discretion. And then there's the whole deflection program that they have recently started, where people with small amounts of substance, either drugs or the paraphernalia, they don't have to arrest them. And so that program's been going on for like almost 2 years now, and they've got 2,000 people connected to treatment, and those are people who absolutely would have been arrested. So I mean, it's a lot. And I just want to share one thing. This kind of sums up how all of this can be aligned, where it's not just one program. Like if you're a journalist working on a story, I see so many, because of all the interest in it now, of an article about here's a cool co-responder program that this community did, and here's a cool crisis training that this community did. But it really takes the whole system working together, so that this is what I was talking about before. Like you can resolve things on the phone, and then you can escalate to mobile teams and then to facilities. But then at every point, there's this collaboration with law enforcement to make it easier for the law enforcement to get the person to treatment than than using the jail. And when you have all of that stuff aligned together with multiple providers doing this, but there's a governance and accountability structure to it that makes sure that all these parts are working together, that's what you need. You need a system of care. Like for EMS, there's a whole system of care for if there's an emergency and a trauma, and you call 911, and there's certain hospitals that are designated for this, and there's ambulances that get paid for. We need that same level of systemic, consistent approach that we expect for other types of health emergencies. So that's my soapbox on that.
Thank you. I'm going to go to the questions from some of the fellows. This is from Nikki Roberts. To what extent do people who are leaving prison and who have been diagnosed and medicated in prison able to continue that post-prison? And are there improvements or not along that spectrum?
Are you talking to me?
I'm talking to perhaps Chris. Slobogan. Yes.
Well, ideally, of course, if someone really needs antipsychotic medication in prison, they wouldn't be in prison. They'd be transferred to a unit that deals with people who have serious mental illness. And then along the lines of what I was talking about before, if they are released, whether it's from prison or this treatment unit that's associated with the prison authorities. There's a treatment plan that is implemented after they leave, either through a community mental health center or some other outpatient facility. Now, how successful is that? Well, that's going to vary from jurisdiction to jurisdiction. The last panel talked a lot about reentry, and reentry can be very poorly run. Transition can be very poorly run, can also be well run. But ideally, there would be treatment plans that would follow the person after the release from incarceration.
In Arizona, the health plans, again, like because they've got such a tight kind of system around the Medicaid here, the Medicaid health plans, if they have a member with serious mental illness who's in jail or prison, they're required to go do outreach and contact them like before they get released. And also they've done stuff like if you are in jail or prison, your Medicaid gets turned off, but and then that's another gap for reentry where then you don't have your health insurance. And so they've done stuff in Arizona where it gets suspended but not turned off, so it's easier to turn back on. And so there's again, it takes a systemic response to look at this as a process that needs to be done.
And this perhaps is for you again, Chris LeBogan. How many states have that sort of stopgap? I know that there are other municipalities that are doing that, trying not to turn off the Medicaid.
Geez, I really don't know. I mean, maybe Dr. Balfour, maybe Margie.
I don't know
knows.
off the top of my head.
I don't have any idea. I think a lot of states are clueless about the systemic problem that Margie just described. They just haven't identified the problem, and so nothing's been done about it. If they were told about the problem, if they were aware of it, hopefully they take care of it. But that requires some federal state cooperation, among other things.
And I will say, because I go around, talking about this stuff around the country and, learn how you have to speak red state sometimes. And so crisis services are nice because, like I said, the clinical goals and the financial goals are aligned. But when you're talking about the justice system, like, what incentive, besides just being a nice person, would the Medicaid director have to reduce justice involvement because your Medicaid gets turned off when you're in jail? And so Governor Ducey, like at some point early, I think in his tenure, did something where he had the department heads meet and look at their budgets and make cross-departmental goals, because ultimately the money for Medicaid and jail and everything comes from the same place, which is us taxpayers. And so that's where there was this goal of reducing justice involvement for people with SMI. And so then when the Medicaid Department Access in Arizona puts out its RFPs for for people to bid on being the managed care agencies, that was part of the bid process, was explain how you're going to do that. And then that's where those requirements came from. So that's a great example of how you can do strategic planning, but people have to be thinking of things as a system and not all these little fragmented parts.
Sure, Lieutenant, I want to ask a question. I'm not in New York right now. I'm in my hometown of Little Rock, and this is a thing that happened in my neighborhood. A young man who was clearly in a mental health crisis. We called the intervention team. They sent 2 paramedics and 2 cops. He was clearly in crisis. The officer said he's clearly in crisis, but he could answer for us his name, the date, and who the president was. And that's the measure of whether we take him or not. And I'm wondering what the parameters are where you are and how often officers go out, know that there's a problem, but can't really do anything.
I think a lot of times we know when there's a problem, but it's not illegal to be in mental health crisis. So if we're out there and they're just talking to themselves walking down the street and they're in mental health crisis, unless we can prove that they're a danger to themselves, a danger to others, or suicidal, they can keep walking down the street. The question about name, date of birth, and who the president is, to me, is an old, outdated system of asking these questions. You really have to ask the questions and dig deep. And for our CIT training and our officers, we probe and we try to get to the bottom of what is going on right now. What can we do to get you the help? We want to keep everybody out of the criminal justice system. It's complete fiction that all we want to do is take people to jail. We don't. I would rather not take somebody to jail and rather get them the help they need in the mental health system. And but the last thing we want is someone to be a danger to themselves, a danger to others, or suicidal. We don't want that either. So if we can,
what are the measures for danger?
If they're threatening somebody, they're threatening that they're going to hurt somebody, threatening they're going to kill somebody, have a weapon that they've actually tried to, we've gone to houses where there are kids who are teenagers who have knives and weapons, and they're literally saying in front of us, I'm going to kill my mom when you leave. I'm going to kill my mom. I mean, that's obviously a danger to others. If they're sitting there firing a gun in the air and in the neighborhood and they say they're shooting at aliens that are above their heads, obviously that's a danger to others, because those rounds are always going to come down, because that's the laws of gravity. So things like that would be a danger to others. It's usually a danger to family members that they're around, or children that they're around, or something to that effect.
So we're going to do a fast rip around because there's Steve. 30 seconds. If each of you would just say what needs to be covered, what do journalists need to be watching or correcting even in our coverage? Chris LeBogan, go.
Well, so I gave you the 3 issues that I think should be covered. But I will also say it's very important for journalists to understand, for the public to understand, that people with mental illness are not more dangerous than people in the general population. There is this myth that people with mental illness are extremely dangerous, much more dangerous than others. That is wrong. It's not to say that psychotic symptoms can't lead to risky behavior, as the officer just described, but this idea of the mentally ill people as others who are very, very different from us. No, there are people with problems that they really have no control over. It doesn't make them more dangerous most of the time.
To me?
Please, thank you, Ginger. Yes.
Sure. I think the most important thing really to know that it's a motto that may be overused, but it's profoundly true. And that is, there is no health without mental health. We all must have good mental health in order to reach our potentials and live with purpose. And I think that the one thing I want all of you please to keep in mind, and that is that recovery, just like any other medical problem, mental health is no different than any other physical illness, and recovery is real. And I can say that after serving over 23,000 people in my courtroom, recovery is real and treatment works, and it is so prevalent. No one is immune from mental illness.
Lieutenant and Margie, in your answers, would you talk about in the context of what COVID has done in this arena, how it's changed what you do, who you serve, and how you're working, and what coverage can come out of that, what news stories can come out of that? Lieutenant, you want to go first?
Sure. Humans are social animals, and we've all been confined to our houses and just our families for the last year and a half. So it's difficult, and it has made people. We have seen an uptick in mental health calls and mental health crisis and suicidal issues. I think Colorado is 4th in the nation in suicides. So I think that COVID has made it more difficult. And also people aren't getting the help they need because their doctors are closed and their doctors aren't seeing them in person. And you can tell anybody what you want over the phone, but usually the face-to-face is where you find out if there's actual mental illness. You can see it in someone's behavior, you can see it in their body language and stuff like that. So I think COVID has made, and the pandemic has made things a little bit more challenging, getting people their help. And once they get the help and once we get into the hospitals, most of the therapy sessions are teletherapy sessions, and teletherapy sessions aren't as effective as the in-person stuff.
Yeah, and we, for that reason, in our centers, we've kept in person. We have like a few physicians who, because of their health issues, and them being high risk, we're doing stuff via tele, but the staff there that's taking care of our patients, they have to be there in person. And so we felt very strongly that that meant the whole clinical team should be there in person. And, when we did all of the things that you do for COVID mitigation. And we, had testing and all kinds of stuff to make sure that our workforce was healthy and safe. And we saw COVID rates among our staff that were no different than the general population. So, we don't think it was spreading within our facilities. To the more general question about what to cover, I think a couple different things is, like I mentioned before, it's like there's all these articles about cool programs here and there, and that's great because that's ginning up interest. But don't want people to think, oh, if we just make a co-responder team, then we've solved the problem. That's the other caveat of that, is that you do need a systemic approach, and things always, and the things are getting kind of conflated because, again, it's great on the one hand because there's all this momentum because 988's coming, and then there's all this attention on policing and like, should police be responding to mental health stuff? And then it gets framed as a policing issue. I would challenge that and say it's a mental health parity issue. Like, if you have a heart attack, there's a system that everyone expects to be there and is paid for by the healthcare system. We don't talk about robbing municipal budgets to pay for ambulances to bring people to the emergency rooms. Yet it's like, that's what for crisis, for mental health, that's okay to be talking like that. We should expect better. We should expect the healthcare system to pay for a system of care that's just as robust as there is for EMS and trauma. And then the last thing is that there are examples of stuff that's working. All the articles that have already been done on various programs that are successful. The link that I put in there for that crisis roadmap has, it really breaks it down as to what would a crisis system, should it look like, what should the standards be? And there's examples of communities that are doing things right. And the final thing is, like, we are at this tipping point, I think, of really being able to transform crisis care, because all the convergence of everything, the 988, the interest in mobile teams, the interest in getting police out of this business, I think, things are all coming together. So hopefully we'll see some good things. And I'm happy to talk to any reporter who wants to talk to me.
Thank you. That was fabulous, Judge Lerner-Wren, Dr. Balfour, Lieutenant Gulli, Professor Slobogan. Thank you so much. Thank you.
Thank you all.
Pleasure.
Let me
Thanks so